Assalamu alaikum. We'll start today, inshallah, the 13th session of peripheral vascular disease. The first presentation, I would like to ask Dr. Fakher Elmasry to present the first presentation, how I do it, deep vein arterialization. Tfadal.
Okay, thanks. Shukran. Assalamu alaikum. So my topic is how do I do it? It's percutaneous deep venous arterialization. These are my disclosure, none is relevant to this talk. Deep venous arterialization is called the last ditch limb salvage. I always put this picture where these are maggot or larvae, and it's a very ancient treatment, which now is coming back because this larva eats all the dead tissues, and it had been used a long time ago. Now it's FDA approved since 2004, so it's very simple to do. DVA is basically a creation between a proximal arterial inflow and a distal venous outflow. There are several methods. The topic today is a percutaneous DVA. Everyone in this room knows that CLI is a dangerous disease. It's as bad as many cancers, 60% mortality within 5 years. Basically, the failure to connect healthy vessels distally is what lead to the CLI and what we call desert foot. It's not a new concept. This was published more than 100 years ago by two surgeons, by Halsted and Vaughan. So it was surgically created, but the problem with this surgical creation, it's always there are valves which prevent the blood flow to go into the venous bed, and also there are many collaterals which steal the blood away. The modern day DVA is becoming now acceptable, and there are many devices coming out, which are going to be one of the speakers next talk about devices which are becoming FDA approved now. These are some of my patients. The toes are necrotic. Anyone with DVA is going to get some kind of an amputation, toe amputation, transmetatarsal, but they're all end-stage problems, and they don't have any other hopes. I encourage everyone in this room to do them because you have nothing to lose. This is an example of an 82-year-old patient, and we do one we saw in clinic, and this is how it looks like. The foot is dry, there is no blood going whatsoever. So before you do a DVA, you have to do a detailed angiogram. Most of these people, we had multiple attempts for traditional recanalization. You have to confirm that you have a good, healthy posterior tibial artery, at least 5 centimeter segment. Cardiac output is important, same as when you do a FEMPOP. You want to have a patient have a decent ejection fraction. Also be careful of patient on hemodialysis. This is an example of multiple cases we have done where we use a lot of CO2 because most of them have stage 3 and 4 renal failure. And if you look at these images, when you come to the foot, there are no healthy vessels in the foot to be able to create them. The calcification, nothing goes, and as you saw, the toes are all necrotic. The other leg also same way. The vessels are very diseased, calcified, and all of these people, we do multiple atherectomies, stenting, and so on, but these vessels don't lead to significant flow. So this is my very first case I've done in 2017. I'm following till today. A 49-year-old patient with a 10 years history of end-stage renal failure, hemodialysis. Already had an AKA of the leg, and now his other leg is necrotic. So if you see the stump here on the right leg, and the left leg is basically very, very dry. This patient was going on his way the following day for a below knee amputation. So was our very first experience, gain access, integrate, and because we don't have any devices, we're doing it basically with the same traditional way. You gain access into posterior tibial vein and posterior tibial artery, and you go back and forth until you find the closest connection between the artery and the vein. And in this case, we were using an outback device. And we finally were able to connect, and we stented this all the way down to the foot. We don't have valvulotome, so you just go and balloon all the valves, and you put a Viaband all the way to the ankle and pressurize. This is how you want to look. It looks like all the veins are pressurized down into the foot. This is how it looked like in a week. The podiatrist called me, and he said, I cannot stop bleeding because it used to be completely dry like plastic, and it was very vascular. This patient has his foot till today, 7 years later. Second case, 82-year-old with lower extremity vascular disease, also renal compromise, amputation of the big toe, the second toe is necrotic. So this is one of the intervention. Again, we're using CO2. And this is how it looks like. Funny here, patient had a bypass. I don't know if you notice this, of the popliteal bypass. We didn't need it because we recanalized it and got the flow to the popliteal. But the problem is when you go down to the foot, there is nothing going down here. So this now in 2018, the Pioneer device is out. So again, we're trying to figure out how we could improve our technique here. So we figured out if we put a balloon on the posterior vein, it's kind of create a body. And now with the outback, we're able to stick into the balloon. So that actually refined our technique. Moreover, the outback has 3 throat, 3, 5, and 7 millimeters. And that became our technique for a while to create the DVA and the fistula, and then we put our stent. And this is a picture you want to see. This is exactly how the veins are pressurized, and this patient went up and healed really well. Going to 2019, we started also refining our technique even more. And of course, this is how patients look like. They're all going for amputation somehow. We started using the techniques called the gun sight technique, which is not a new technique. We have been using gun sight technique in the liver for several decades. And the second thing we figured out that if we gain access into the vein, we evaluate the venous if we have a good venous flow before we actually stick the artery. So here we put a tourniquet, stick the vein, and do a good venogram, and this patient have very good, healthy venous bed. And now we gain access into the arterial side, and this is a technique. Last year at the MEVAC meeting for the Mansoura, we did a live case, and this technique doesn't need anything. You just need 2 snares, and it's the same microfunction needle used for the access into the groin. You put the 2 snares, one in the anterior posterior tibial artery, one in the posterior tibial vein, and you stick through the skin into both snares. And once you are both snares, you put a wire, take the snare out, you pull the first wire out of the groin, take the second wire out of the access into the posterior tibial vein, and from there is a case of straightforward. So you see the balloon, you see the valve, destroy them, and put your wire bond. And this is a picture you want to see at the end here. This is when and we had to go and loop it actually. And we had very nice venous bed, and this patient also actually went to heal. This is a 73-year-old patient with marked advanced necrosis of the lower extremity and DVA. So we went ahead and I'll skip a case so that for the interest of time, 65-year-old female patient who had transmetatarsal amputation. So the stump has opened and there is poor flow. Same thing, we started gaining access to the venous side first, make sure that the veins are healthy, and went and stuck the arterial side. Same, from that point we started using the gun sight technique all the time. It shortened our procedure significantly. And now we're exclusively using the gun sight technique. So you put your 2 snares, stick them, take the wire out from the arterial side, from the venous side, balloon it, and from that point it's a piece of cake. You go ahead and do a wire bond here, and you get this picture here. This is my last case and an interesting case. This is a retired physician, and all of his children are physicians. So it's a high-profile patient, VIP, and they came to us specifically to do this work so that we are, we consider the best. And we went into a major complication. I thought I would show this case here. A patient had already amputation of his left leg 2 months prior, and they're all very, very nervous here. So me and my partner, we scrubbed in this case together. So we gained access, and we did the gun sight technique. Everything was going fine here. First of all, we tried to do traditional technique here, and we couldn't. So we went for a DVA, put our snare, put our wire, put our stent, and we ruptured. At this point, this is an absolute disaster. These people came all the way, several hours away, and now we have a complete rupture of the vein. We didn't know what to do. We tried to find a vein in the foot here. We gained access, but the problem, we found ourselves, we were in the other posterior tibial vein. So now we want to cross from the medial posterior tibial vein to the lateral posterior tibial vein at the ankle. So my partner looked at me and I said, how about this? Let's create a DVA between one posterior tibial vein to the other, And he said, oh, that was never done before. I said, exactly. So let's try it on a VIP patient. So now we're in the venous side at the ankle. We have a snare on the posterior medial posterior vein, the other snare on the lateral posterior vein. We stuck it with one needle, and now we're able to cross from one posterior vein to the other. And we just basically created the whole thing, and we're able to solve the case. So in summary, I think DVA is a very important to have it in your armamentarium as a very viable tool. It's called a no option. You could do it. And with this technique, you don't need any devices. You just need a $5 snare. You put your two snares, the same micropuncture, and something important for you to be able to offer your patients. Man, thank you.
Thank you very much, Dr.